Welcome to everyone all over the world. Such an honor, really, to be a part of this program and to be speaking with my colleagues worldwide. My name is Frank Ascoli. I am a physicist. I work in Providence, Rhode Island. And joining me in this lecture is Dr. Anuja Jhingran, and she is at the MD Anderson Cancer Center. Today's topic is going to be evaluating normal tissue constraints and plans for treatment. This is a very, very important part of treatment planning and will help make clinical decisions that will affect the outcome of the treatment to improve it and also to minimize the side effects. My talk is going to be a little more physics oriented. I'm going to be talking about some of the definitions that we use in evaluating plans. And I'm going to be presenting several plans from my center and go over how we evaluate those plans. The International Commission on Radiation Units, the ICRU, years ago came out with their report number 50. And this was about the time that IMRT, intensity modulated radiotherapy, started to be used in cancer center treatments. They wanted to come up with a series of standard definitions, which I will review here. These are critical definitions, and all clinicians speak this language, so it's important to learn these definitions. The gross tumor volume you see in red in the center, that's called the GTV. Beyond that is the clinician's idea, impression, knowledge of how the cancer microscopically can spread beyond the gross tumor. That's called the clinical target volume, the CTV. The most important one for planners is the planning target volume, the PTV. The PTV takes into account all of the uncertainties in the planning and delivery process. The PTV can include the slight variation in calibration of the machine from day to day. The PTV includes internal motion of the tumor and the area that needs to be treated day to day. The PTV also takes into account any uncertainty in the setup reproducibility day to day. The PTV is critical to making sure that most of the dose, the intended dose, is delivered to the target. The PTV ranges sometimes very tight from 2 or 3 millimeters, and sometimes can be as large as a centimeter around the CTV. Of course, we don't always confine 100% of the dose to the PTV. There's some spillage beyond the PTV, and that is the treated volume. And then when you include the penumbra of the beam and leakage from the head of the radiation machine, you have the irradiated volume. But the main volume of interest is the GTV, the CTV, and the PTV. There is also another acronym called OAR. That stands for organ at risk. That is very important in detailing, outlining, quantitating how much dose is delivered to organs which should not be treated. The most important tool that we use is the dose volume histogram. And every planning system, every 3D planning system has the ability to produce dose volume histograms, DVHs. The DVH is developed by the computer, and this is a slide share which I borrowed, and it very, very nicely shows how the dose volume histogram is developed, is determined, is calculated. On the left, you see a head and neck cancer. You see the eyes, the optic nerves, you see the nasal septum, and you see a tumor right below the left eye. It's outlined in red and in yellow. Now, that is a dose distribution also that is superimposed on that tumor, and the computer puts these grid lines, grid squares, voxels, into the tumor volume and begins to accumulate how much dose is in each voxel. So on the right, you have what's called a differential or true histogram. And as you can see here, I'll use my pointer here, there's dose on the bottom on the X, and how many times you get a count on the y-axis. So for example, in the very middle of the tumor, where you would expect the dose to be high, you're going to have a lot of voxels. There'll be several hot spots within the tumor, and you see those on the right. And then on the left here is the trailing off, the fall off of the dose. So this is called the differential histogram. We don't generally look at the... Was that a question that I should answer? I would have to have somebody translate that.
No, you're good.
Okay, thank you. Now, if you take that differential dose volume histogram and you begin to add them one on top of another, each histogram added, it continues to add. And as you can see, you end up with this typical characteristic DVH curve. It's a sigmoid style curve. It starts off in the high dose, goes up mainly where the dose is, and then over to 100% for the tumor. So from adding up these individual histograms, you get what's called the cumulative dose volume histogram. And this is the one that clinicians like to look at. It means that the dose to the organ that is being looked at goes from a maximum here to a minimum here. And this is how much of that organ sees all of that dose. What's important is this slope right here, especially for the target. A dose volume histogram, you want to have it flat across the top, and then you want to have it fall off sharply as your PTV goes into normal tissue. So a good dose volume histogram for the cancer would be flat across the top, falling off sharply, and trailing off. Dose volume histograms can take any number of shapes. This is a volume here that receives a dose here. And this would be a poor dose volume histogram for the tumor, but it may be a satisfactory histogram for an organ at risk because it doesn't see maximum dose all the time. Here is an example of two dose volume histograms for the target, for the tumor. The green one is much, much better than the red one. The green one has a very steep fall off, trails off to a high dose point. The red one, however, has a broader shoulder, so there's less dose delivered to the target, and a more gradual fall off with a higher dose delivered elsewhere in the target. So this shows more dose inhomogeneity. The green one shows maximum dose homogeneity. And with all dose volume histograms, a worse plan for an organ at risk would be when the dose volume histogram trends up to the right, and a better plan for an organ at risk is when it falls off very, very sharply in the low dose region. Some issues with dose volume histogram, they don't really quantitate hot spots and cold spots very well. The shape can be very misleading if you don't know how to read it. Dose volume histograms can only be calculated if the doctor or the physicist or the planner has contoured an organ at risk or a target volume, and you have no spatial information. By that I mean it doesn't show you where in the target the high doses are. It doesn't show you where in an organ at risk the high doses may be. So it's very important to know how to read these dose volume histograms and watch the shape of the dose volume histogram. In my center, we have developed objectives and constraints for all of the different cancers that we treat. So This is an example sheet of a lung cancer. And typically this would be 60 gray in 30 fractions. And I want to point out a couple of points here. I want to point out a couple of entries here that we will explore a little bit more. So for this lung cancer, this is a 3-field lung cancer plan. The doctor would like to get greater than 95% of the PTV getting the desired dose. So the doctor expects that whoever's planning this is going to get the 60 gray at least given to 95% of the PTV. And then one line below that, see right here, 99%. The doctor wants that 99% of the volume, essentially the entire PTV, needs to be covered by 93% of the treatment dose. So that's called an objective. But you can't have objectives without having constraints. So let's look at one constraint here. Less than 20 gray going to 35% of the lung. Now you may ask, well, wait a minute, we're treating the lung. How can you get less than 20 gray to 35% of the lung? You'll see in the statistics that we calculate, we actually subtract out the clinical tumor volume, and we look at the uninvolved lung on both sides. So a critical statistic here would be this one right here, where the volume that gets 20 gray has to be less than 35% of the contoured lung, whether it's the ipsilateral or contralateral lung. And you can see how it's even broken down into what volume gets 15 gray, what volume gets 10 gray, what volume gets even 5 gray. So that's an example of objectives and constraints. Here is a typical 3D plan, and it shows the GTV, CTV in the center here. In blue, all around it is the PTV, that's the margin that the doctor included to take into account all the uncertainties. And then you see the dose lines. The red one is the prescription of 60 gray. And you can see where this field, and this field are coming in. Contoured would be the spinal cord and a margin around the spinal cord. And also the esophagus is contoured. And below here, you see the heart is contoured. So we look at objectives to the tumor, constraints to the organs at risk. This is what the dose volume histogram looks like. So as I said before, anything to the left and down here is good. These are all the organs at risk getting very low dosages. Look at only 50%, 40%, 30, 20, 10%. Getting 10% getting some of this high dose. So those are good statistics. And for the PTV here, the PTV and the GTV, you see how you have a nice sharp shoulder, a very steep fall off, and there's always going to be more dose than the 60 gray. And that's what this shows, that there's going to be some hot spots of about 65 gray, but there'll be very little. Most of the dose is right up in here, 99% and 95%, as was written in the objectives. So this is a good dose volume histogram. When you treat a left-sided lung the way in the position that it is in this plan, you can't help but get dose to the brachial plexus. So the brachial plexus was contoured, and this is the shape of the brachial plexus. And a lot of times part of it is very, very close and almost into the tumor itself. But you can see where the brachial plexus dose is still limited to about 62 gray, and the doctor felt that that was acceptable. The planning system that we use is a Philips Pinnacle planning system, and it has the ability to give very detailed statistics called a scorecard for how we're doing, how we evaluate the plan. Now, look, I've put circles around several of the important ones. Here's the PTV for the primary. The PTV, remember, 60 gray had to go to 95%. How did we do? Well, we actually got 95.782%. So that's green. It met the criteria. Remember, the doctor wanted 93% of the volume to get 99% of the dose. How did we do? Oh, pretty good, 99.998%. So that's green. And then the statistic for the lung that I showed, 20 gray had to be 35 cc or less. How did we do? Oh, 28.5%. That passed. So all of these were met. And this is a quick visual that a clinical person can look at and know that the objectives and constraints were met and that the plan is a good plan. The planning system without DVHs gives you the organs, the targets, the objectives, their volume that was contoured, minimum, maximum, mean, standard deviation, and units. So one thing I always look at is spinal cord right here. Spinal cord. The cord volume was 27.8 cc's. It had a minimum value of 28.9, and that's in centigrade. It had a maximum dose of 26.18, so very, very low dose to the spinal cord because our limit is always 45 gray. So that's good. And then look at the expansion. We expanded the cord, and even the expansion of the cord, we always provide a 5 millimeter expansion around the cord just to check the fall off to the cord. Even the expansion was under 45 gray, or very close to 45 gray. Breast cancer treatment. We treat a lot of breast cancer, as I'm sure all of you do, and we've developed objectives and constraints for our breast cancer plans. I want to go over one point here, which is the first course whole breast chest wall, maximum dose to 0.03 cc. So this is maximum dose to a small area, so-called hotspot. The hotspot, we don't want the hotspot to be greater than 108% of the treatment dose. But look, there's a variation here because not all patients you can get that 8% maximum. Sometimes we have to bump it up a little bit depending upon the shape of the breast and the chest wall. The doctors are willing to accept from 10% to 15% hotter, but the goal should always be less than 108% for the hotspot. So that's an objective. And as a constraint, on the left side especially, we're very concerned about dose to the heart. And these are the constraints that we've developed for the heart dose. You can see here, we don't want the mean dose to be more than 2.2 gray. We keep the heart dose very, very low. And if there's going to be 50 gray to the heart, then it has to be a very small amount, 2 cc's. But our goal is to keep the mean dose under 2.2 gray. We have a limit on the brachial plexus, 60 gray, not to exceed 66 gray. And then we also, for our plans, we measure, we quantitate, we calculate what the liver dose is, because sometimes these breast fields stretch down so far that they clip part of the liver. The most critical structure in the heart is the LAD, the artery that is near the radiation field. And that artery we want to keep as low as possible. So sometimes the doctors will actually calculate the ascending, the artery that is close to the heart. Thyroid dose has to be as low as possible, and the esophagus has to be as low as possible. This is what the plan looks like. And you can see some hot spots here and here. You see very nicely the tumor cavity, because the patient had surgery, the lump was removed. This is where the tumor was. This is the PTV that the doctor drew around it to take into account all the uncertainties. And you can see the red line here very nicely covers the whole breast and falls off very sharply. This was a very nice patient to plan because her heart was relatively small and far away from the radiation fields. But here's what the fields look like. This is a tangent field on the left side. You can see the contralateral lung is measured, and we also look at dose there. That's going to be minimal. And we would also calculate dose to the ipsilateral lung, although it's not shown in this cut. Pinnacle by Phillips has a way of calculating dose volume histograms by looking at statistics based on cubic centimeters. The way we read this, if you have a Phillips computer, the contoured hot volume is the maximum at 0 cc's. It's so zero dose goes to 589.92 cc's of heart. As you start to step up in dose, you have less and less of the heart being involved, and that's good. The way Pinnacle works is you use the high dose numbers here. So let's look at 1000 centigrade. And then you come down in this column, 250 centigrade. So if I was reading this, I would say 1.38 cc's received 1000 plus 250 or 1250 centigrade. So this is the way you calculate those bins, those little bins that I talked about. It's calculated this way by looking at how much volume got how much dose. So you can see from this that most of the high dose region in here, it's all 0. None of the heart got any of the high dose. And actually 1.38 cc's receiving 1250 centigrade was very, very good. So this is how you read the dose statistic. It still isn't a graph yet, so we need to look at the graph. Here's the graph of the treatment that we showed. PTV right here, GTV, PTV. And over here, we see the organs at risk, very, very low, very favorable dose volume histograms. Looking at an interesting statistic, we said that we wanted 0.03 cc's. 0.03 cc's should get it should be less than 45.96 gray. That was the 8%. If you bump up the prescription dose by 8%, you get 45.96. We want 0.03 Cs to get that. Unfortunately, we couldn't make that. We had slightly hotter than that. At 45.96, which is an 8% hotspot, we had 0.27 cc's, more than the 0.03. So that turned the color to yellow. Yellow means that it didn't meet this primary goal, but we also have secondary goals. And our secondary goal goes up to that 10 or 15%. And we want 0.03 to always be less than 48.94. In fact, the hottest point is 46 gray, and that went to 0.27 cc. So it met the secondary goal, which was yellow, did not meet the primary goal, or it would have been green. But the doctors generally accept green and yellow. I'll show you an example later on of what happens if the goal is not met. Here is the statistics for the breast. You can see the heart contoured at 589 cc's, minimum, maximum, mean. Cancer of the uterus. We treat this usually post-operative, and we always follow it with a brachytherapy boost. So in this first case here, in the first course, the doctor prescribed 45 gray pelvis radiation, standard dose to the pelvis for the uterus, cancer of the uterus. This was post-hysterectomy, so this is going to the pelvis to treat the pelvic nodes, and it will be followed by a brachytherapy boost. Let's look at one constraint here for the rectum. less than 80% of the rectum should receive less than 40 gray. So less than 80% has to get, less than 80% cannot go over, less than 80% cannot go over 40 gray. So we want to keep the dose very, very low. We want 40 gray to 80% or less. Sometimes you can't always do that. And an acceptable variation here would be 50 gray. But the goal here is to keep 80% of the rectum under 40 gray. Sometimes you can't do that. And we'll see that in this example. Here's what our fields look like. This was a volumetric modulated arc therapy, VMAT IMRT. And the nodes were contoured. Where the uterus was, the tumor bed was contoured. And we want to give dose to the pelvis, to the nodes, and we'll follow it up with a brachytherapy boost. But this is what it looks like. And I want you to look down here in the lower left, right here in brown. You'll see the rectum outlined right here in brown, lower left. You see it very nicely on the sagittal view. Unfortunately, a good part of it is into the PTV, and the doctor felt that to spare the rectum, to keep the rectum below our goal would have been impossible. You'd be sacrificing coverage to the tumor volume here. So the doctor made the decision to overrule that constraint. So here's 45 gray, or here's the one with 40, 40 gray to 80%. I mean, so I'm sorry, to 80%, 40 gray to 80%. We didn't make it. It was 86.7%. So that turned out to be yellow. But then we also added another constraint saying that 45 gray had to be under 60% of the rectum. We did not make that. We went up to 71%, and that turned it red. But whenever there is a red entry, which means the constraint was not met, the planner has to put a note in, and the doctor approves this. 70% of the rectum overlapped the PTV. Now, the feeling is that it's still a low enough dose, and we'll try to do a lot of rectal sparing with the follow-up brachytherapy. So the doctor, however, overruled this constraint because to keep within that constraint would have sacrificed dose where it was needed the most. So that's why it turned red. But every time there's a red area where the objective is not constrained, we are required to put a note in, and the doctor approves the treatment. Here is what it looks like. You can see that the rectum actually follows almost the PTV because a good part of it was within the PTV. So this is not a good DVH for an organ at risk. These are better DVHs for an organ at risk. And some of this, the bladder in yellow here, you can see is a little bit better. We did femoral heads also, contoured a few other things that we tried to keep out of the radiation field. Treatment statistics that Phillips Pinnacle gives us. Rectum, you can see that the highest dose to the rectum is actually 47 gray. The doctor felt that that was okay to go over our constraint of 40 and 45 because it's still not going to be bad treatment, and the doctor wanted the patient to get maximum benefit from that treatment. Cancer of the rectum is another area that we treat. 50.4 gray and 28 fractions, 46.2 gray and 28 fractions, 50.4 gray and 28 fractions, pretty typical. Look at the objectives here. At least 98% should get 93%. At least 98% of the rectum should get 93% of the dose. And then we have an acceptable variation. We'll accept 98% getting only 90% of the dose as a variation. That's not the primary goal. This would be more of a secondary goal. If you can't meet this one, you certainly have to meet this one. And then, as far as hot spots within the rectum, less than 10% of the rectum should not have a hot spot over 5%. Less than 5% of the rectum shouldn't have a hot spot of over 10%, and we don't want any part of the rectum to get over 15% of the dose. Acceptable variation here, for a small bowel, yeah. So maximum dose to the small bowel, 50 gray, but we'll accept up to 52.5 gray. Bladder would be an organ at risk. Femoral heads, we contour all the time because of the bone marrow. We don't want those to get too high a dose. Small bowel, certainly, we try to limit the dose to the small bowel as much as we can. Here's a typical treatment plan for cancer of the rectum. The patient is prone. The patient has a support under her back here. Patient has a support, which helps to push the small bowel out of the way. You can see the contrast here in the small bowel. It's pushed well out of the way. You can see the outline here in red, the GTV. And then we have in blue all around it is the PTV. The doctor put a very generous margin around this, wants all of this treated because there are some nodes included also. Here's a scorecard which shows how we did. So 50-40 to the rectum, right? 50-40 to the rectum. That line, we want 98% to get at least 93%. But look at, I mean, we actually got no problem. We had the dose of 46.87 was the target dose that went to 100%. Here's the maximum dose. If we use the, I believe it was the, let's see, we wanted the maximum dose here, not to exceed 15%. So maximum dose right here, see it? Zero cc's got that 15%. 0 cc's, 0% got even 55-44. So these are good statistics. We over here for maximum, we wanted 10% to get less than 52-92. We ended up with about 13%, so it turned yellow there, but that was still acceptable. So in summary, for my part of the talk, dose volume histograms, extremely critical in evaluating a plan. It gives you a common knowledge that the clinicians can all talk about, and plans actually have a way of being scored. And the planners and the physicians can look at the quality of the plan in terms of dose to the target, dose to the tumor, dose to the healthy tissue around it, and come up with a measurement system, develop a table of objectives and constraints, and score them by dose volume histogram and a table of objectives and constraints taken from that dose volume histogram. With that, I'm going to turn the talk over to Dr. Jhingran, and I hope that this little technical explanation will help you to understand how to evaluate and use the tools of your treatment planning system a little bit better. Thank you.
Good morning or good afternoon or good evening, wherever we are. So what I'm going to do is actually go from exactly what you've heard so far, and we're going to go and look at some plans and see what we think about these plans. So we're actually going to look at plans. So I want you to take from what you just heard about, and let's look at some plans, okay? So here's a breast cancer plan. So just to help you, and I know you can't see the line so well, so we're treating this breast cancer patient with the 250 times 15. So our isodose line is going to be that 42 gray line, which is the red line. So let's look at this plan. So this is the plan that we're going through multiple sections down in the field, right? So what I want to do is, so let's look at and see, what do we think about this plan? So a couple of things. One is left-sided, right? So one, we want to make sure that the dose isn't going to the heart. Two, that there's not so much dose to the lung, but the biggest thing is you want to be able to cover the entire breast with your isodose line, which is what we talked about. So just to give you some ideas about how we do certain things, before we even look at this plan. So when we're thinking about left-sided, heart is going to be our biggest issue. In most centers in the United States now, we're actually doing deep inspiration so that we move the heart away from the field so that we can reduce our heart dose. So most left-sided breasts, at least in the United States, are being treated with deep inspiration. And in fact, some of our right-sided breasts are even being treated with deep inspiration because then you can reduce the dose to the lung as well, right? So those are some things that we're doing. We are doing it by visualization, but you could also do it by teaching a patient. So while you're doing a CT scan to do the planning, you can see if the patient takes a deep breath, the heart moves away. So you can teach the patient how to breathe through her treatments so you can also reduce the heart dose without having to look at it. But anyway, so let's look at this plan. So what are we looking at? So we're going to look at, I can say the normal tissues look pretty good, right? We're not getting very much dose to the heart. In fact, the green line, which is the 2100 gray line, is going nowhere near the heart. Very little lung. But what is the biggest problem though? So do you think this is a great plan? No, I'm going to tell you it's not a good plan. Because why? Because we're not covering the breast. So yes, the normal tissues look beautiful, right? Yes, I love this plan. But to be honest, we can't just look at the normal tissues. So that's important. Yes, the normal tissues are important, but you've got to cover your disease, right? And that's the problem with this plan. It's not covering the breast tissue. So here's another plan. So let's look at this. So the same thing, we're going to look at 3 things or 4 things, right? 2 things. You want to look at your normal tissues, and you want to make sure that you're covering the area that you want to cover, right? So same patient. Again, we're looking at the red line, which is really the line that is our prescription line, okay? So there is a little bit of hot spots right here, but that's pretty normal because of the way her anatomy is. But as you can see from the previous one, the red isodose line is much better covering the entire breast tissue, right? And we can see we're still not, yes, we're closer to the heart, but we still don't have dose to the heart. And the amount of lung is actually pretty low. So this is a better plan, not because of the normal tissue, but because we're covering the area we want to cover. So this is just a comparison, right? So let's look at good and bad. Which one is good and bad? Same patient, right? This is bad because we're not covering the breast tissue, even though our normal tissues are looking great, right? This is good. Normal tissues are good, but key, we're also covering our disease. So it's so important. This is the key thing I want everybody to know. Yes, we want to reduce normal tissue tolerance, but you also want to treat the area you want to treat, right? So this is just a comparison. So you can see the normal tissues all exist. So we're looking at a DVH, the dose volume histogram, right? So the dotted line and the straight lines of the 2 different plans, but you can see they're all good. So the normal tissues are all great, right? It's the tumor bed that we weren't covering. And so it's important to look at both of these things. Moving on. So this is what we do. So we at MD Anderson, we actually fill out our normal tissue restraints. So every patient has this filled out. So for a breast who's going to get 50 gray with a boost, the spinal cord has a goal. The heart, which should be a V20 less than 4% or a V10 less than 15%. And the most important, total lung, V20 less than 35%. So this is actually given to our planning person, whether it's your physicist or your dosimetrist, and this is what we're trying to hold to. But again, remember what I just said. We can hold to this, but you also have to treat the disease. So moving on, let's look at this rectal case. Okay, and I want you to look at it, and let's look at it, and let's look at the things that we're looking at. So we've already talked about the rectal case, right? We talked about a rectal case. Most of the time, these patients are treated prone. Key is you're going to treat the whole rectum. So the rectum is not even a normal tissue that you're going to worry about. What you're going to worry about is your bladder, your femoral necks, and your small bowel. So let's look at this case, and you're going to look to see, you're going to look at your small bowel, you're going to look at your femoral head, and you're going to look at bladder. But the other thing you want to do is you got to make sure that you're covering your disease. But you can see, even if, and I like, when I look at plans, I look at it multiple ways. First I look at the axial. The axial, I want to make sure my 50 gray line, which is the red line, is covering my disease. So right here, so you can see this, if you can't see it, I'm pointing this out to you, it's covering my disease. So the 50 gray line is pretty much covering my disease, right? Then I look for hot spots, and I want to make sure that there's not very many hot spots, and you can see it's probably not very much hot spots. But then the next thing I look at is how much dose is going to my bladder and how much dose is going to my other normal tissues, and in this case, small bowel. But you can see here is the 47 gray line and the 45 gray line. So quite a bit of the bladder is actually being treated by this dose, okay? So decent plan, it's covering all my thing, but the bladder is getting a little bit high dose, right? So let's look at the next plan. Here's my next plan. Okay, so let's look at this, okay? The other thing, like I said, we look at hotspots and making sure there's conformity, right? So you can see the dose is breaking up. That 50 gray line is breaking up somewhat. There's also little bit of hotspots right here, right? We saw that. Lots of hotspots here. And this is, again, not quite as conformal because we're using IMRT. So next plan, this is another plan, right? What do we see here? Wow, right? All the hotspots are gone. So that's a good thing, right? My dose, the 50 gray line is covering everything, no hotspots. The bladder is actually getting less dose. If we go back here, look at this. And I know it's hard to see, and I'm sorry, but see, look at this red. Here's the red line. So look how much of the bladder is getting the full 50.4. We go down here, look at this 50.4. It's conforming more to the normal, to the tumor target and treating less of the bladder. So this is actually a better plan, right? Less hotspots, more conformal, and less dose to the bladder. And this is what we use as our normal tissue constraints for rectal. So the key, femoral heads are important, and you want the V45 less than 20%. Small bowel, you want the V50 less than 10 cc's, and then the bone marrow V10 less than 9.9%. So those are what we normally put in for our rectal cancers. But the key is, and this is the biggest, and I wish I had shown it side to side, so I do apologize. Look how non-conformal this is. And that's important to remember. You also, especially when you're using VMAT or IMRT, you really want it to be a very conformal plan with less hotspots, but also treating less of the normal tissues as possible. And look at this, look how pretty, no hotspots. And we really are getting out that bladder. So cervix. And this one, actually, I do have side to side. So you can see as we're going down. So we do treat a lot of intact cervix as well as post-op cervix. And I'm sure that you guys actually will probably see a lot more intact cervix. So as we go down, we'll look at this. So this patient had positive notes, so we're treating the periortics. So what are we worried about? What normal tissues? You're going to worry about the kidney. You're going to worry about small bowel. You're going to worry about spinal cord. So as we go down, so what we're looking at, so what are we looking at? So we're going to give 45 gray to all of my CTV, as we talked about, plus PTV. So the blue, the color wash, is your CTV plus your PTV, okay? And what you're going to look at is, what is my 45 gray line covering? So here you can see the 45 gray line is here. There's actually no 45 gray line, or little of that 45 gray line. But as we go down, you can see the 45 gray line is really much more conformal here, where it really is just treating my PTV. As we keep going down, you look at your 45 gray line, and you're looking at how much bowel it's treating. And you can see, again, this one much more conformal than this one. As we go down, what are we seeing here? Now this one, you can see where the pink line, which is the low dose line, is actually going up and treating the muscle, right? So this is now becoming less conformal, right? Where the pink line is not treating muscle, right? So this plan is actually probably better than this plan because now we're treating more of the muscle and other tissues that we don't want to treat, right? But I think it has to do with, you have to look and see, what do we want to worry about and what is important to us? As we go further down, again, this is now treating more soft tissue anteriorly. So what's going to happen? Anteriorly, then the patient's going to have skin reaction. Down here, this is actually treating more of the sacrum. What is going to happen? The patient will have a skin breakdown, right? See this? Where this is actually getting off that skin. So the thinnest area, we're off that skin. So we will reduce skin breakdown here, and we will reduce skin reaction here. So, right, so this plan may be actually a better plan because we're reducing the skin, which is actually something that we don't have in our normal tissues. So there are things, I mean, we're always looking at normal organs at risk, which is rectum and bladder and small bowel. But remember, certain skin toxicity also is really important. And in this case, this plan will actually have less skin toxicity than this plan will. So I would pick this plan. And we go further down, again, now it's a little bit more about the same, but what do you see here? More dose to the femoral head. This one is getting off the femoral head. Now we know that the femoral head is not as important as the femoral neck, but still you want to reduce the dose to the head and the neck because that's where fractures happen. You also want to reduce dose to the bone, because this is where your fractures are going to happen, right? So again, little bit more conformal, little bit less conformal, but we look at everything and I'm gonna say, I like this plan better, right? So you have to look at a lot of different things and just shows you the different doses and the different tissues, and you can decide which plan is better and which plan is not, but you gotta make sure you cover the area you want to cover. So this is what we give, and this is actually a post-op thing, but we do look at all of this. But I agree with what we heard from our earlier talk. You also have to look and make sure you're covering the disease, right? But our small bowel, we want to keep the V40 grade less than 30%, the bladder V50 less than 50. This is really hard to get a lot of times with intact cervix. The rectum less than 80%, femoral heads V40% less than 15. Spinal cord, less than 45 grade, maximum less than 36, and then the bone marrow. But again, what's not here, which is what I showed you, why I would pick one plan over the other, is the skin toxicity. And you really do have to look at that because these patients will get skin breakdown. So there are other things, even though we don't have them listed here, you also have to look at. So lung, and I know this is a little bit hard to look at, but we've already talked about lung. So this patient's actually is getting 60 gray. And you can see where, and I know it's a hard field, but you can see that it's a red line, right? And the red line is very conformal here. Very nice, very pretty, right? Conforms right to this. This is a decent plan, right? So what do we think about this plan? So and what is the differences? So let's look at it. What are the differences? And I want you guys to look at it. So here's one plan, very pretty. Here's another plan. So this is actually a 3D conformal plan, right? So what it is giving beams at different angles. But you can see it's not as conformal as my VMAP plan is, right? This plan really is covering the disease completely and not really treating other normal tissue. Where this plan, you can see it's spreading out the lung dose. It's not as conformal, right? And this is an interesting case because in the United States, we actually sometimes have to give comparisons of why we're using IMRT versus 3D conformal. And we actually use this for an insurance issue. So you can see where the 3D conformal really does treat a lot more lung, a lot more heart, and is not as conformal as the IMRT plan, which isn't treating as much of the lung and the heart, right? And just to show you the DVHs, you can see the DVHs of the different things, right? So the heart, and so the solid line is the good plan, and the dotted line is the bad plan, right? The conformal plan. And you can see where the 3D conformal plan was treating much more normal tissue than our IMRT plan, which is the solid line. The heart, the lungs, everything is getting more dose with the 3D conformal plan than the IMRT plan. And even here you can see actually, so the coverage though is actually probably a little bit better, more with the 3D conformal, right? We saw that. But we still have great coverage with the IMRT while sparing the normal tissue. So you have to look at both, as we talked about. And this is really what we use. And I think the most important thing is total lung, and that's key. It can't just be the right lung. You've got to make sure you spare the total lung. And this is what, so the mean lung dose should be less than 20 gray. V20 gray should be less than 35%, and V10 should be 45 gray. And I think this is probably the most important thing, and what we look at really more than anything else when we're treating lung is the total lung dose. And then of course kidney, which we didn't talk about, which is pretty much standard. V20 should be less than 32%. So that's all I have. So what kind of questions can we answer? And I know we're at the end of the hour, so I'm going to stop sharing, hopefully, maybe stop sharing and open it up to questions. Is DVH enough to evaluate a plan? No. Like I said, you can't just look at the DVH. You've got to look at your plans. I mean, I like I showed you, the DVH was probably really good for that really hot non-conformal plan, but there was hot spots everywhere, right? So no, DVH is definitely not enough. You have to look at the plan. You really have to look at that plan. Other questions? So one of the questions was, we use contours for the bone as yes. So that's what you should do. 100%, you should use contours of the bone as your bone marrow. Yes, I totally agree with that. Yeah, how do we evaluate bone marrow dose? Frank, do you want to answer that one? That's a tough question. So I'm going to let you answer that one. How do you evaluate bone marrow dose?
Okay, I just unmuted my mic. So we use the femoral heads mainly, mainly because of the fracture, as you said, but also we want to keep the dose low because of the implications to the bone marrow. Unless you actually contour, you cannot evaluate. So if you're really concerned about bone marrow dose, then it would be appropriate to contour more bone. We don't do that because the plan is so conformal. If we can keep the femoral head dose low, we're assuming then that the rest of the pelvis, where most of the bone marrow is, will also be low.
Same thing. Yeah, exactly the same thing. Oh, that's your question, Frank. What's the difference between differential DVH and integral DVH? That's definitely a physics question.
Yep.
Oh, you just muted yourself.
Okay, sorry, I just muted myself. Let's see if I can share my screen again.
Frank, you're muted again.
Okay, now I'm unmuted now. Sorry about that. So I showed a slide early on, which very nicely showed the difference. And I want to see if I can share my screen again. Can you see my screen? I'm not sure if I'm sharing it.
No. Do you want me to do it? Because I can go back to that. Oh,
good. Yeah, if you go back to that slide, it's the one it shows the differential and then the integral. So go back to the one. It's got a I'm sorry.
Can you see my slides?
Let me see if I can see your slides. Okay, good. That's the one. Yeah, both of those. So yeah, so go back to that first one with the head and neck cancer. Now, yeah, right there. Perfect. Thank you. So the computer creates a grid, a three-dimensional grid for the whole area being contoured. That's the calculation grid. And those grid spacings could be, anywhere from a millimeter by a millimeter to 3 millimeters by 3 millimeters. It all depends on how you break it up. But what the differential DVH does is it just starts adding how many of those squares have the same dose. So if the goal is, say, 70 gray, as you can see in the middle, where the dose is fairly uniform, there'll be a lot of those voxels that contain 7D gray. As you move over to the periphery, there'll be fewer and fewer voxels, and there'll be voxels of a lower dose. So you actually create this histogram. This is a real good mathematical histogram that breaks up, that shows you by its height how many voxels have how much dose. So that's the differential one. That's not the one we look at. The one we like to look at is the next slide, which is the cumulative or integral DVH. And this slide, which came from SlideShare, really shows how beautifully this thing is calculated. You start on the right with the highest dose, and there's not a lot of voxels that have the very, very highest dose. And then you quickly ramp up to the tumor dose, to the prescription dose. You just keep adding one pile on top of another, just keep adding. And you create this very nice sigmoid shape, which describes the dose volume interaction. And that's the one we look at. So from the differential DVH, we actually just do the addition. Integral implies that it's the summation. It's the summation of all those voxels, and then draw a line connecting the top of it, and you end up with this very nice cumulative DVH, which explains a lot about the uniformity of the dose within the tumor, and the shape, the slope of that is critical. You want a very steep slope for the tumor, which shows that the dose falls off sharply and you don't have a lot of inhomogeneity. You don't have a lot of hot spots. You want a very steep slope for the tumor, and you want a more shallow slope way to the left and down for the organs at risk. So I hope that answers the question for you. Yeah, and the next slide shows that generally, if you're looking at organs at risk, the worst plans have DVHs that trend up to the right. The better plans for organs at risk have DVHs that trend to the lower left. So the shape of the DVH is a good indication of the plan quality. You want to be very careful that the organ at risk doesn't have an extremely steep slope. If the organ at risk is a serial organ, meaning like a spinal cord, or an esophagus, it's critical. If that DVH slope is very, very steep for an organ at risk, then minor changes can greatly affect the dose to that organ. For example, if you had a rectal DVH that looked almost like an objective DVH with a very steep slope, well, very little dose differences, very small changes in dose could greatly affect the dose to the rectum. So you don't want to be in that situation with an organ at risk. And sometimes the slope can be so steep that even if you include, say, the effect of daily cone beam CT, 30 or 40 gray at the end of the treatment, or if you include the effect of neutrons, if you're using 10 MV or higher, if you include the effect of the neutrons, you could be so quickly moved into a high dose region for an organ at risk. So you want the organ at risk to have a lot of tolerance and a much slower, lower, gentler slope, not like the sharp fall off of the target.
Frank, maybe you can also speak to the topic of if you've got your coverage and you have to choose between two plans with DVHs where one has a much lower maximum dose for the OAR but more low dose to the OAR versus a plan that has kind of a similar gradual fall off but has a much higher maximum dose to the OAR. What sorts of considerations would you keep in mind when picking the better plan in that case?
It becomes critical in the lung, for example, and the lung is not that tolerant of radiation. And the expression that we use in one of the clinics I cover, it sounds a little cold and abrupt, but dead lung is dead lung. And that's the saying. At 30 gray, you're going to have dead lung, and it's not going to recover, and it's going to forever be dead lung. So it depends on the organ. The lung is not very tolerant.
That's why that total lung is so important, because
yes.
it calculates your low dose, right? And that's why I was emphasizing total lung. In fact, total lung is the key, the most important thing to look at. It's not right lung dose or left lung dose. It's total lung dose. So you're right, Frank. That's exactly true.
Yeah.
The lung is not tolerant.
No. And it also depends whether you have serial organs or parallel organs. If you're concerned about kidney dose, and one kidney may get a higher dose and may actually have damage, there's still another kidney to take over. It's not quite as bad as, say, spinal cord, where dose to any part of the cord that exceeds 45 gray or 50 gray, or depends on the literature that you read. If you want to be real exact about it, 60 gray is where the data starts to become very significant for cord myelitis and complications. But once any small area of the cord gets 60 gray, I mean, that's a serial organ. That patient will have a terrible, terrible side effect from that radiation. So it's also the nature of the organ. The liver, for example, dose to the liver. Well, liver's a large organ, and high dose to a small part of the liver is not that big a deal. High dose to a small part of the esophagus is a big deal. The patient can't swallow at that point. So serial organ versus parallel organ, also important to consider.
Thanks very much for that, Frank.
You're welcome.
I think that was pretty much all the questions. Is that correct?
I think so. There's some discussion about the sacral plexus and the brachial plexus.
So two different things. Brachial plexus is very sensitive and very important. And you're right, we didn't write a brachial plexus. That's actually, and I didn't because I put in, and I need to look at that up. I didn't because we were just doing breast, but you're right. Brachial plexus is a very sensitive organ, and it's very important. And it does need to be contoured for all head and neck and breast cancer and anytime you treat the axilla. So unlike the sacral plexus, the brachial plexus is very sensitive to radiation. And I have to get, I don't know, offhand, I can't remember because I don't treat breast as much. Frank, do you know what the dose constraints for the brachial plexus is? I should have put that down. That was my fault.
Yeah, we like to keep it well under 66 gray. And
that's how we went to 60. I don't think we even go past 60.
Yeah. So 60 gray and less, and over 60 gray with extreme caution.
Right. Yeah. I mean, the brachial plexus is so important. And that is, I mean, like for head and neck and for anything, I think ours is 60, and I'm almost 100% sure it's 60, because if you overtreat the brachial plexus, you'll have a dead arm, and that's not what you want. So brachial plexus is very, very important. And the sacral plexus, I agree with what Ben said. You know, for initial treatment, I mean, the sacral plexus can really tolerate about 65 to 70 gray. But if you're retreating, you've got to be very careful with it. And, you know, just FYI, and it's an interesting concept, right? We don't think about the sacral nodes because they really do tolerate radiation very, very well. But I've had like 3 to 4 patients of mine who had intact cervix, and 2 of them actually couldn't walk like a couple months afterwards. And it wasn't my external beam. The dose that they got to the sacral nerves, and we looked at it, was from the tandem and the implant. And because my tandem and implant were so posterior and right next to the sacrum. So that's where, so like when you're treating an intact cervix, where the dose to the sacral nerves come from actually is from your brachytherapy. You have to be very careful about the position of your implant and make sure that it isn't so posterior and stuck to the sacrum. And because that's the worst thing possible, to have a 40-year-old not be able to walk because you've overtreated the sacral nodes.
Anuja, I saw one case I reviewed many years ago. Exactly what you said. It wasn't the external beam, it was the implant. It was the tandem, actually.
Right.
that was reversed. It was backwards. It was put in upside down. And the tip, it was a curved tandem. The tip of the tandem, which usually carries one of the high activity source, like 20 milligram radium equivalent, that tip of the tandem was so close to the sacral plexus that the patient ended up in a wheelchair for the rest of her life because it was clearly overdosed because the tandem was put in upside down.
Well, it was probably because the tandem was, the uterus was retroverted and they didn't. Right.
And they got into big trouble with that.
Right.
Yeah.
No.
Yeah.
One more thing that I'd like to kind of emphasize from like a physics and dosimetry perspective is that the sacral plexus and the brachial plexus are both invisible on the CT. And so it's very important for your clinic to have in place very particular guidelines on how to contour these structures, because you cannot see them on CT. And so you need to use like proxy structures in order to contour them. If you don't have specific guidelines for how to contour these structures, and everybody is kind of just contouring them the way they feel like they should be contoured, the dosimetry that you get for them is not going to be consistent, and it's not actually going to tell you anything useful or important. So when you're going into treating these types of treatments and using these structures, like make sure that you have step-by-step guidelines and like some examples, and make sure that the people who are contouring these things are properly trained, either by the physician who is treating these structures regularly, or by a physicist or dosimetrist who is very experienced with contouring these structures.
And there's a question about whether the brachial plexus should be contoured for breast cancer. So, our standard is that we are contouring the brachial plexus for all breast cancers. We are contouring the brachial plexus when we're treating the superclad period. And I think that is very important for head and neck or breast cancer, right? So it's not just breast cancer. You do need to contour the brachial plexus when you do superclads as well. Very interesting about the question about the rectovaginal fistula. Usually the rectovaginal fistula will get worse if it's already present. We usually do a colostomy and then we radiate if it's a true rectovaginal fistula. But it has to be a true rectovaginal fistula. I mean, if the patient really is having stool coming in, into the vagina, then a colostomy and then you radiate. But if it's not, don't do a colostomy until the patient becomes symptomatic, because then they're maybe stuck with that colostomy.
And Anuja and Frank, I just want to thank you so much for your lecture today. I was able to listen to the second half of it. I thought it was wonderful. Can't wait to watch the recording for the first half. Tia, you did a great job moderating. And to everyone who's here joining us, we've sent you some homework assignments. So for those of you that have your treatment planning systems, give a shot at planning the cervical cancer case that we gave you. For those of you that don't have a treatment planning systems, try to write what your goals would be, both for your target and for your OARs. Here, Anuja did a really nice job of showing some examples of goals that she uses for OARs. We also shared with you the Quantec guidelines, which can be a good starting point. So please take a chance at that. And for the physicians and radiation oncologists, you have your contouring assignment. So a lot of things to practice these 3D techniques. And then lastly, for the medical physicists, Tia has just sent out instructions for QA assignment. And I think this will be a very good start with making sure that everything that we think we're doing, we are actually doing accurately. So that's a lot, but everyone's doing a good job. So thank you so much.
I think the biggest takeaway, though, I really want to emphasize is please don't just look at your DVH and think it's a great plan, because I promise you that's not the only answer.
Yes, thank you, everyone. And so I think that we're going to end here unless Frank or Anuja has anything else to add. Thanks, Ben, for reminding everyone of their homework. And I'm going to see you guys all on Thursday and next Sunday for QA lectures. So I'm looking forward to that. So thank you, everyone, and enjoy the rest of your evening.